thank you so much for the very nice and comprehensive presentation earlier on the COVID in pregnancy. Without wasting much time, we are Dr. Prof. Kartini Rahmat and Dr. Farna Fazli from Biomedical Imaging. Today, we are going to talk about a very interesting topic. It's very new, recent development. Today, Dr. Farna Fazli is a senior lecturer from Biomedical Imaging University Medical Center. She underwent her postgraduate training at University of Leicester and obtained her FRCR in the UK, and has also obtained her fellowship in breast imaging and nuclear medicine. Her clinical interests and research contributions are mainly focused on the nuclear medicine, breast imaging, as well as neuroradiology. She has published numerous articles and publications, as well as presented in national and international conferences. So without further ado, let's listen to Dr. Farhana Fazli's talk entitled The Role of PET-CT in Breast Cancer Management. Over to you, Dr. Farhana.
Thank you very much, Dr. Fazli, for the kind introduction. So my name is Farhana Fazli. As Prof. Kat mentioned, I'm currently a lecturer in biomedical imaging. So just let me share my screen first. I hope all of you can see my screen and can hear me loud and clear. So the talk of my lecture today is on the role of PET-CT in breast cancer management. And I hope this lecture will help to answer any questions that any of you who might be wondering when is the right time to do PET-CT when looking at a patient with breast cancer. So I hope at the end of this lecture we will get a bit more information and really help us to make a better decision. So my lecture will actually encompass several parts. First, go through some of the basics. The PET-CT protocol in PCF, Malaysian and international guidelines for PET-CT in breast cancer, as well as some evidence of the role of PET-CT. We'll go through some of the disadvantages, and then I would like to present a study that the UNMCT has done on breast cancer histology and hormone status versus FDG uptake, and just to go through a little bit of the future developments in this area. So the objective of my lecture is to discuss the indications of PET-CT in breast cancer cases, to compare the current guidelines and also demonstrate current evidence, and also to present a study that was done in UNMC. So as I'm sure all of us know, breast cancer is actually the top cancer in Malaysia. This is from data in the National Cancer Registry from 2019. And also when we look at the 5-year relative survival rates for breast cancer comparing with other countries, unfortunately Malaysia is a bit lagging behind from the developed countries around the world, and this one's from data in 2018. So we may be wondering about PET-CT and how does it work. So it's a bit different from the usual radiography and computed tomography that we do, in the fact that in this case we actually inject the patient with the radioactive material, and then the radioactivity is emitted from the patient and is detected by the machine. Whereas normally, like the CT scan and X-ray, the radioactivity comes from the machine, it goes through the patient, and then it's detected by the detector. So it's slightly different. So the very important component of the PET-CT will be the radiopharmaceutical. And the radiopharmaceutical is actually the tracer, which is a chemical that we know goes to a certain part of the body. Let's say we are interested in reading the bone. We have to know what actually goes to the bone, and that will be our tracer. And then we kind of bind it with a radioactive material or radioactive atom, and that forms our radiopharmaceutical. And this is what we inject into the patient. And so this cartoon just tries to explain that in very as simple terms as possible, that the radioactive atom on this radiopharmaceutical will lose this radioactivity, and then it will form a positron. So you need to be familiar with electrons. So positron is just the opposite, basically. It is a positive charge instead of a negative charge. And within the patient's body, there will be collision of the positron and electron at certain speeds. It will cause an annihilation reaction, which produces gamma rays. So this is actually quite an important thing because once that annihilation reaction occurs, then there is production of very high energy gamma rays. And this will exit the patient's body, so we can imagine this is the patient, and in opposite directions. And then the PET scan has a ring of detectors which detect the gamma rays coming out from the patient at opposite sides of the ring. And when it hits the detectors at the same time, and then the machine knows that that's probably occurring from a certain location. It can calculate where it comes from, and then the uptake is then shown in the image that we know now as the PET scan. And so if you'd like to watch this video, actually take snippets from this video, it's very entertaining, and you can always take the QR, just take a picture here and you can have a look at this video, how PET scans work. So basically, just now what I was trying to illustrate is how to get this image on your left hand, so the PET scan, and then combine it with the CT scan. So that's why it's also known as hybrid imaging, and then you get this PET CT scan, which is this telephone image that most of us are familiar. So the PET scan itself just shows the activities in the cell. And then CT scan shows all the anatomical information that we are all very familiar with. And then PET CT scan helps us to localize, the activity is in the patient's body. So, talking about radiopharmaceuticals, there are multiple radiopharmaceuticals that can be used for different types of cancer. But in breast cancer, in 1972, the sodium fluoride, ethylfluorine was the one that was first used. And then in 2000, the 18F fluorine FDG is the one that started to be used. And then in actually 2020 now, they are starting to use 18 fluorine FES. And this is actually when we actually tag the radioactivity to estradiol analog. So this is good for patients who have cancers with estrogen receptor positive and things like that. It is actually quite common. So talking about sodium fluoride, actually sodium fluoride has a very high affinity for the high turnover sites of the skeleton. So it's actually also used in bone scans. So it's mainly used to evaluate breast cancer patients with bone metastasis, and also to help to check for the response of the treatment. It has a higher sensitivity and specificity than bone scan alone. And because osteoblastic lesions are relatively acellular and have a lot of bone matrix, so they are better detected by sodium fluoride compared to the normal bone scan in which we use 99 and the Asian methyl diphosphonate. So moving on to FDG, which is our main interest for today. So it actually correlates with cellular metabolism because, as we know, the FDG actually stands for fluorodeoxyglucose. So it tags to the glucose, and a lot of tumors in our body require a higher metabolism, and use up a lot of glucose. So this is where our FDG will actually kind of target or will be really attracted to. So the indications it may be rare to stage, stage, response to treatment. Some of the benefits is that it can be higher sensitivity and specificity for bone scan for bone metastasis patients in general. And also it can have a high sensitivity and specificity for extra-axillary lymph node metastasis. It's also superior to conventional imaging to look for distant metastasis. And in patients with recurrent metastatic disease, actually FDG PET could actually substitute the usual CT and bone scan that we do. So in CTUM, we do PET CT protocol a bit differently from other places. So I'll just let you know how's the difference. But initially, all patients have to be fasted, and we give about 3.5 megabecquerels per kilogram of 18 fluorine FDG. We inject that intravenously, and then we do the whole body PET CT using our PET CT scanner from the vertex to the mid thigh, about 60 minutes after we give the FDG. And we do contrast enhanced CT, so that's the main difference. So a lot of centers elsewhere, they don't actually give contrast with the CT, but here we do. And then, so we do the contrast CT first, and then followed by the PET CT at about 10 dead positions, taking about 45 seconds for each dead position. And then if let's say the patient has any renal function or any allergies, we would do a plain CT. We also do a plain low dose CT thorax just to rule out any lung metastasis. And then we can do MPR, so multiplanar reformation of our images to have a glance at the patient in three dimensions. So this contrast enhanced CT part actually allows a complete staging of the patient as well as extra information from the PET CT. So from the PET as well. So that's why we feel we are giving kind of a complete package to the patient over here at PET. So moving on to some of the guidelines that are available. So actually in 2019, we have the CPG guideline for management of breast cancer. And even then actually has already mentioned that about PET-CT. And what they said was that it's not quite indicated in staging of clinical stage 1, 2 or T3N1 breast cancer. And the reason for this is because of the high false negative rates in lesions that are small, especially those that are less than 1 cm, and in those low-grade breast cancers. And also there's a low sensitivity for detection of axillary nodal metastasis, especially in the early stage because the axillary nodes may be very small. And also in this early stage, the clinical probability of having metastatic disease is actually very low. And there's a lot of false positive scan due to other conditions that the patient may have, such as other breast diseases. So I think FDG PET is actually most helpful where there are equivocal result from the other staging studies, okay? So such as a CT scan or bone scan. So move on to the European Society of Medical Oncology Guidelines, or ESMO, in 2021. So they did mention when they were looking at patients with newly diagnosed or recurrent metastatic breast cancer, they mentioned that CT here that it could actually replace the CT of the chest abdomen and bone scan. So it could be a replacement. And they did say that it might provide some earlier guidance in monitoring bone-only or predominant metastasis, but they said that more trials are needed to study the impact on treatment decisions and overall survival. However, for early breast cancer, PET-CT is not listed as a recommendation, but they say it may be useful for high-risk cases, so those with high tumor burden, aggressive biology, or any features that may suggest metastasis. So again, it's kind of a case-by-case basis. So those inconclusive cases mostly. In the NCCN guideline, the National Comprehensive Cancer Network, in 2022, so if you notice that in the non-metastatic invasive breast cancer, they didn't mention PET-CT at all. But in the more than T2 stages, then they did mention FDG PET-CT is an option. But definitely a bone scan, or they said sodium chloride PET-CT is also an option. But you said if let's say you already have a FDG PET-CT and it clearly indicates a bone metastasis, you don't need to do a bone scan anymore. So you can actually rely on the FDG PET-CT. And also, again, they did mention about if there are any equivocal or suspicious staging, FDG PET-CT can be performed at the same time to help. And it can also be helpful in identifying unsuspected regional nodal disease or distant metastasis. Okay, but they did say that it's not recommended in the staging of clinical 1 or 2 or operable stage 3 T3N1 breast cancer, and it's due to the high false negative rates for small lesions, high rate of false positive scans in patients without locally advanced disease, low sensitivity for axillary nodal metastasis, and low probability of these patients having detectable metastatic disease. So quite similar to what our Malaysian CPG guidelines said. So let's go through some of the evidence that's available. So talking about the initial staging. So initial staging, so maybe some of the patients with early stage disease. So some of the problems with primary tumor detection with PET-CT is there's lower sensitivity. And this is especially if the tumor is less than 1 cm and it's due to partial volume, so kind of like it's smoothing out of the uptake due to the limited spatial resolution by PET-CT. And some cancers, such as the lobular breast cancer, there's typically a low FDG ability. So if you do PET-CT and there's no uptake, doesn't mean that there's no cancer in the breast. And also, there's a low specificity as well in these cases. So So for primary tumor detection, the mainstay of ultrasound, mammogram, MRI is still much more reliable compared to PET-CT. And then for nodal metastasis detection, because they could be small in the early stages, there's a low sensitivity of about 66%. It was reported in the study. And specificity also is about 93%. And there can be false positives due to other causes, as COVID vaccination causing lymphadenopathy was definitely brought up as one of the causes. But it can be good for unsuspected existing nodal metastasis. So nodal metastasis elsewhere, like in the infraclavicular, supraclavicular, or in the internal thoracic chain. And it was also noted that FDG PET had sensitivity of 100% and specificity of 99.1% for pleural metastasis, compared to 50 and 100% with the normal CT scans. And also for distant metastasis, FDG PET-CT had a sensitivity of 100%, specificity of 98% compared to 60% and 83% for conventional imaging. And also FDG PET-CT is found to be more sensitive and specific than CT or bone scintigraphy for detecting lytic or mixed bone metastasis. We'll go through that in a bit more detail later. So here I have an example taken from this Gohart et al. And this patient actually had about 5.2 centimeter mass in the left breast, and clinically had a lymph node enlarged, which was enlarged, but it was movable. And so initially the classification would be T3, N1, and not. However, the patient had the FDG PET-CT and he showed the high uptake in the primary tumor over here and also in the liver. And this was, of course, not detectable clinically. And also there was uptake in the sternum. So after this FDG PET-CT, the TNM classification had to be changed to T3, N1, and N1. And it was now found to be metastasis. So it actually changed the management of the patient. Now moving on to recurrent disease and what the role of PET-CT is. So FDG PET-CT can be quite beneficial when other modalities are inconclusive, as mentioned in the guidelines earlier. It can be good to identify isolated metastatic lesions and also local, regional, and relapses. And a sensitivity of up to 91% noted for FDG PET-CT when it was compared to CA153 and other imaging modalities by one study. And in one study of about 100 patients, FDG PET-CT had higher diagnostic accuracy than bone scan and contrast enhanced CT. It was found to have fewer false positives and false negatives. And in a meta-analysis done in 2016, covering 26 studies in 1,752 patients, the sensitivity and specificity was about 0.9 and 0.81 respectively, which is quite high. And looking at treatment response, the good thing about PET-CT, especially if you have a comparison, is that you can actually do a quantitative measurement of the metabolic changes, which is the SUV value that we always mention in our reports. So it was found by a study by Schwartz et al. That there is actually statistically significant difference between the SUV values in responding and non-responding metastatic lesions. So it's good at evaluating whether there is any response or non-response. As we all know, we want to know this as soon as possible in these patients, because then we can change the management and hopefully find something that will work better for the patient. And also it can detect skeletal metastasis earlier than CT scan. So let's discuss a bit further about skeletal metastasis and the differences in PET-CT versus bone scan. So we know that CT can be inaccurate because we know that breast cancer can cause lytic as well as sclerotic metastasis. So sometimes maybe after treatment, the treatment can actually cause sclerosis in the bone of the patient. So we could erroneously say that maybe the patient has a new metastasis, but actually it could be osseous healing due to the treatment. So this is the problem with CT. And even bone scan also could detect this inaccurately. It can actually still show some high uptake sometimes immediately after treatment. There can be even an increased uptake compared to the previous scan, and that may be erroneously thought to be, progressive disease. But actually, the increased activity it can be due to just the increased osteoblastic response. And so actually, this is detected much better with FDG. So FDG wouldn't show such an increase. So that will help us to tell that, this is actually improving. So here's an example of a patient with bone metastasis due to breast cancer. So if you look at the image A, this is actually our planar bone scintigraphy, and this on the right is your PET-CT images. So this is done at roughly the same time, and initially it was thought that there were just a few areas of increased uptake, so not much bone metastasis probably. But then when the patient had the PET-CT, you can see there's just diffuse bone metastasis. It's just all over, and then you can see there's a lot of lytic lesions as well on the CT. The problem with osteolytic bone metastasis, sometimes it doesn't show up very well on the bone scan. So something that we need to consider when we are imaging these patients. And carrying on with treatment response, so neoadjuvant chemotherapy, as you know, is a very important treatment regime in our breast cancer patients. And it's shown that there is a good correlation between the response to neoadjuvant chemotherapy and SUV changes in the PET-CT when it was compared with the pathological examination result. But at the moment, I think MRI is still the mainstay and differentiating response in neoadjuvant chemotherapy patients. So what are the disadvantages of FDG PET-CT? I think I've alluded to some earlier already, but we'll just go through again. So tumors with low FDG uptake, such as invasive lobular carcinoma, they may show as a false negative, but actually there is a tumor over there. And also smaller lesions due to the spatial resolution may not be detected well on PET-CT. Tumors with low Ki-67 expression also tend to have a lower FDG uptake. And reconstruction artifacts may show increased uptake. So it's just like a post-surgical changes. Degenerative bone disease as well can sometimes show increased uptake. So that's why the presence of the PET-CT is very important, because the features and the CT can help us to identify that this is just degenerative and not actual bone metastasis. And then breast expansion also could show some increased uptake, as well as lung infection versus lung metastasis. So I'm going to present some of the results from a study that we did recently. So we looked at about 100 patients with invasive ductal carcinoma and lobular carcinoma. So lobular carcinoma is a rarer form of the cancer, so that's why we didn't have as many. But we did find that invasive lobular carcinoma had a significantly lower SUV max, so that's the value that we normally calculate on our PET-CT, compared to invasive ductal carcinoma. Okay, and this is already also has been shown in other studies, in other papers. And then we looked at the histological grade of the tumors. So most of the patient population had grade 2 and grade 3 grades of the cancer. And it was significantly associated with a higher SUV max. So higher tumor grade is associated with higher SUV max. And then we looked at the subtypes of cancer, hoping to see if there was any a correlation between the SUV values and the subtypes. But there was no significant difference between values and the different breast cancer subtypes. So just to go through briefly, so the luminal A type is ER/PR positive, HER2 negative, whereas the luminal B is all positive. HER2 is ER/PR negative and HER2 positive. And then we have the triple negative, which ER/PR and HER2 are all negative. Okay. So just to show some examples of the cases from our study. So these are all patients with breast cancer, and you can see actually they are all hypermetabolic, and that's how we would normally describe in our PET-CT report. So they are showing high activity or high uptake compared to the rest of the kind of the breast or the patient's uptake in the rest of the body. So especially in the one that's all positive, ER/PR, HER2 positive is showing very high uptake. But all are hypermetabolic, and we would normally measure the SUV value. Okay. And this is an example of an invasive lobular carcinoma. The one that I mentioned earlier tends to have a low SUV value on PET-CT. So on this plain CT image, we can see an ill-defined lesion here, but it may be a bit difficult to really identify and without the clinical history and everything else. But we can see that on a diffuse PET-CT image, there's not really much uptake here. It's comparable to the rest of the tissues. And these are the images for the same patient showing the mammogram. So on the mammogram, you can see there's a very irregular high density area here in the outer region of the left breast and also in the upper region. So this would be suspicious to our eyes. And then when we did an ultrasound, we saw a very ill-defined mass, which is actually quite large, actually about 5 by 1.7 centimeters. And then the MRI showed very clearly. So it's the most obvious one actually. It shows a very enhancing left breast region. So on what could we say from our results is that invasive lobular carcinoma had a significantly lower SUV max compared to IBC. And also a higher histological gain is significantly associated with a higher SUV max, but there's no significant difference between SUV max and the different breast cancer subtypes. So just to go through some of the future developments that are in store for nuclear medicine and breast cancer. So there are lots of new radiopharmaceuticals that are being developed. One of them being the fibroblast activation protein inhibitor, which is probably one of the more exciting ones. Because as we know, most cancers, they produce these fibroblast activation proteins from the cancer-associated fibroblasts. And most cancers will show uptake with, with this radiopharmaceutical. Because as I mentioned, there are some problems with invasive lobular carcinomas and certain low-grade carcinomas not really showing uptake, but with this it should show uptake. So that will ease the detection and also the assessment of these patients using PET-CT. And also another one, the FACC, is actually just looking at the amino acids that are produced by the cancer cells. And so because they produce that certain amino acids, we kind of tag to those amino acids, and that's how we show the uptake on the PET-CT. And also there are some agents that are being produced which will tag to the human epidermal growth factor receptors. So those patients who are HER2 positive, this will be an exciting development for those patients. And also therapy is also they're looking at lutetium-177 labeled HER2 therapy. So this is a very targeted therapy for patients with this HER2 positive receptors, and also radium-223 aromatase inhibitors. And also PET MRI would be quite an interesting development as well, because as we know, MRI shows very impressive soft tissue differentiation and is very good at detecting tumors. And if we can combine PET with that, maybe there will be a lot of benefit to the patients, especially in assessing response and also in detection of the tumors prior to surgery. So in conclusion, I'd like to just reiterate that FDG PET-CT is indicated, especially in metastatic and recurrent breast cancer, is very good for assessing treatment response. We get a quantitative type of result. But I'd just like to mention that actually there is no definite SUV uptake cut-off for all patients with breast cancer. It's actually case by case. Each SUV that we produce for that patient is compared to some of the base measurements compared to other parts of the body like the mediastinum, the spine. So we compare with that patient. We don't have a cut-off that is universal for all cancers. Okay, so especially if you have a few PET-CTs for the patient, it will be perfect for assessing the response to their treatment. However, in early breast cancer, PET-CT is still not the first-line investigation due to all the issues that I mentioned earlier. And PET-CT as well is shown to have benefit over contrast-enhanced CT in clinical metastasis in breast cancer patients. So these are my references. And with that, I thank you very much for your attention. Pass the floor back to Prof. Fatima. Okay. I think let me just okay. So I think with that, this probably let's just have a look at okay. So I think there's a question here. With so much uncertainty about the results of PET-CT in breast cancer disease, do you envisage one day it will be a monitoring method that dies in natural death? Okay, that's a very interesting question, Prof. Chai. So I believe it will be a very long time before PET-CT dies the death if it does. I think we can even see like things like CT, the usual CT scan that we are doing is still going very strong, even though it has been in use for quite some time. Even mammograms as well, it's still going very strong. There are further developments with contrast enhanced mammography. So I don't think PET-CT will die very soon. I think it will take some time. There's more developments coming. As I mentioned, there are new radiopharmaceuticals that will help to detect cancers, and it will be more. I think it will be easier to detect with the new radiopharmaceuticals that are coming up. There won't be so much problems on certain cancers being detected and certain cancers not. I think it will be easier to detect the cancer hopefully, and with better spatial resolution, maybe even smaller cancers will be detectable. Maybe we won't need to do CT scans. This I think in PTM at the moment, some patients they don't need to go for a contrast enhanced CT. They just have the PET-CT because it's like a one-stop shop. They get the staging CT as well as the PET information. So I don't think going to die Elizabeth very soon. It will be a long time. All the developments as well as the targeted therapy that will be in line, I'm sure, very soon. Thank you very much for that question. So I think with that, we probably can end today's UM Health session. I thank all of you for your kind attendance and participation, and wish you all a very good day. Thank you.